Hello, I'm Stewart. I'm an orthopedic surgeon specializing in hip and knee replacement with OrthoVirginia here in Richmond, Virginia. Today, I want to take some time to explain complete muscle sparing knee replacement and how it can completely transform a patient experience with knee replacement. Total knee replacement can be a life-changing surgery. It can alleviate the chronic pain of arthritis in the knee, but if you ask anybody who's ever had a knee replacement, they'll tell you it's not an easy recovery. Even in patients who have a great outcome with their knee replacement, they'll even tell you that those first 2 or 3 weeks are pretty tough. Why is that? Biggest reason probably is that we're taking a saw and cutting the ends of your bones and hammering metal into place. That part's pretty much unavoidable. But one thing we can change to try to improve that pain is we can change the way we get down to that bone by changing our surgical approach. So when we talk about knee replacement, really there are three main approaches to the knee: the medial parapatellar, the mid-vastus, and the subvastus. So let's take a look at each of them and see what that means. Medial parapatellar is our traditional knee replacement. Over 90% of the knees done in the US are done via medial parapatellar approach. To do this, surgeon starts along the patellar tendon, comes up along, then comes around the kneecap, and then goes up along the quadriceps tendon, effectively dividing the quadriceps muscle in half. When we do that, we completely detach the vastus medialis, the big meaty muscle on the inside of your knee. We detach that from the rest of the quadriceps and from its distal attachment into the extensor mechanism. The next approach, the mid-vastus, again, starts with an incision around the patellar tendon, curving around the kneecap. But then instead of going up through the quad tendon, this approach will then cut straight through the muscle belly of the vastus medialis in order to gain exposure. You can imagine with these approaches that when you cut these muscles, the surgeon has to repair them back at the end of the case. And so when you do that, you go in and repair this muscle here or back through the quadriceps tendon, you repair that. Every time that patient goes to fire their quad when they're walking after surgery, they're getting tension pulling across that repair. It's literally been sewn back together. Every time they go to bend their knee, they feel like there's something ripping open across the front of the knee, and that's because something's trying to rip open, the repair where that muscle was cut and brought back together. Now let's compare that to a subvastus approach. The subvastus is the only true muscle sparing approach for knee replacement. In this, we come up again along the patellar tendon, curve around the kneecap. But then, rather than cutting the muscle, we swing around the quadriceps muscle, around the vastus medialis, and then elevate the entire quadriceps mechanism over the front and slide it in one intact unit. We then access the joint capsule, do the procedure, and then at the end of the case, we close the capsule and slide the whole thing back over without having to attach any of the muscles from their attachment into the extensor mechanism. You can imagine that this is going to cause significantly less pain and also going to preserve a lot more strength to the knee in the patient's recovery. So now when they are effectively, when the patient is recovering, they go to bend their knee, they are not feeling any ripping across the front of the knee because there's not a repair that is trying to hold up. They're not going to have that constant vice-like feel across the front of the knee. And so they're going to recover with stronger, faster, and less pain than in traditional knee replacement. So why aren't most knee replacements done via this approach? The simple answer is really probably just that most surgeons are not trained on the subvastus approach during their fellowship or residency programs. You learn what you learn, and then you do it in practice. The subvastus approach is not something new. It originally described in 1929 by a German surgeon. Then it was kind of lost for a while. There really wasn't any textbooks or any journal articles until 1991. Dr. Aaron Hoffman published an article kind of bringing it back to life. But even then, it has still kind of remained on the periphery of joint replacement. Again, the main reason that probably is the case is that it's not being taught at our teaching institutions, and we tend to do things the way we learned how to do them. There are pockets of the country where the subvastus approach is more common. Here in Virginia, you've probably heard the term the jiffy knee, which is a trademark term by a surgeon in Virginia, describing the way he does his subvastus approach to the knee replacement. But all in all, nationwide, this is the minority of knees that are done this way. And I think when I ask myself, why is that the case? I think it really comes down to doing what you're comfortable with and then not asking yourself, how can I make this procedure better for my patients? For me, that's really what it came down to, is I knew I could do a good total knee the traditional way for my patients, but I wanted to improve that patient experience in the first 2 or 3 weeks after surgery so they could recover faster and with less pain. So that kind of led me to adopt the subvastus approach. Ever since I started with the results I've been seeing, I haven't looked back. One of the other reasons that subvastus is probably not as prominent nationwide as it maybe should be is it can be a little harder to do. And one of the knocks on it is that it can be harder to put the parts in properly and in good alignment. This is where we can really combine modern technology with the Mako robot and the precise cuts that we can make. And we can combine Mako and the subvastus approach, and we can still make perfect cuts, get perfect balance just as easily as we can with a quad cutting approach. And we can still give the patient a great long-term knee with everything positioned perfectly, but do so in a way that can give them a chance at a faster recovery. So thanks for tuning in. I hope you enjoyed this and got something out of what it really means to have a muscle-sparing knee approach. I feel it's important for patients to be educated on the surgery they're going to have. It's your knee. You need to have the information. And so hopefully these videos, you found it informative and answered some questions you might have had. Take care.